Morning students, today's class we will see about the preterm labor. The definition: preterm labor is defined as one where the labor starts after 22 weeks of gestation and before 37th completed week, that is less than 259 days counting from the first day of last menstrual period. Contractions are less than 10 minutes apart, resulting in progressive cervical changes or cervical dilatation of 2 cm or effacement of 75%. Why do we care? We care because of it is the second leading cause of infant mortality, second leading cause of after congenital anomalies. Relationship between mortality and gestational age is striking and falls exponentially until term. Preterm birth is responsible for 3 by 4th of neonatal mortality and half of long-term neurological impairment in children. The risk factors are divided into three categories. The first one is medical obstetrics, that is prior preterm birth, previous second trimester abortion or miscarriage, cervical incompetence, uterine cervical abnormalities, hypertension, diethylstilbestol exposure. Current pregnancy related include anemia, multiple gestation, placenta previa, abruptia placenta, fetal anomaly, hydramnios, abdominal surgery, maternal infections, maternal bleeding, cervical effacement more than 50%, previous preterm labor, uterine distension, cervical incompetence. And third is demographic and behavioral include maternal age less than 20 and more than 35, low socioeconomic status, single parent, smoker, drug dependence, low pre-pregnancy weight gain, inadequate antenatal care, and psychological stress. Clinical manifestations include uterine cramps, menstrual-like cramp, intermittent or constant, uterine contractions occurring at the interval of 10 minutes or less, low abdominal pain or pressure, that is pelvic pressure, dull low backache, intermittent or constant, increase or change in vaginal discharge, feeling that baby is pushing down or that something is in the vagina, abdominal cramping with or without nausea, vomiting or diarrhea. The prediction of preterm labor or delivery includes symptoms of preterm labor, uterine contraction more than per hour, fetal fibronectin protein that we can see later, present in the fetal tissues from 16 to 20 weeks and then at term. If this appear early, it suggests labor starts early. Cervical length is short or less than 1 inch and effacement is 80%, vaginal bleeding prior preterm birth. Diagnosis by regular uterine contraction with or without pain at least 1 in every 10 minutes. Dilatation of cervix more than 22 cm and effacement 80% of the cervix. Length of cervix measured by transvaginal ultrasound by less than 2.5 cm and funneling of the internal os. And pelvic pressure, backache and with or without vaginal discharge bleeding. It is better to overdiagnose preterm labor than to ignore the possibility of its presence. Preterm labor is very unlikely when the cervical length is more than 30 mm, irrespective of the uterine contraction. Fibronectin is a glycoprotein produced by fetal membrane and functions as an adhesive to hard membrane against the uterine myometrium. Normally, it is found in the cervicovaginal discharge before 22 weeks and again after 37 weeks of pregnancy. Presence of fibronectin in the cervicovaginal discharge between 24 to 34 weeks is predictor of preterm labor. When the test is negative, it reassures that delivery will not occur within the next 7 days. Prevention of preterm labor is by primary prevention, secondary prevention, and tertiary care. Primary prevention include aim at reduce the incidence of preterm labor by reducing the high risk factors. Secondary care, it includes screening tests for early detection and prophylactic treatment, that is tocolysis. Tertiary care aimed to reduce painful mortality and morbidity after diagnosis. Community education, that is role of early and regular prenatal care including dental care, duration of normal pregnancy, consequence of preterm pregnancy, conditions that increase the risk of preterm birth. During pregnancy, adequate nutrition, quit smoking, teach signs and symptoms of preterm labor, progesterone supplementation in high-risk patients. Management of preterm labor includes to prevent the preterm labor onset if possible, to arrest the preterm labor if not contraindicated, appropriate management of labor, and effective neonatal care. The predictors of preterm labor include clinical predictors are history of prior preterm birth, multiple pregnancy, presence of genital tract infection, symptoms of preterm labor, and the biophysical predictors include uterine contractions more than 4 per hour, Bishop score more than 4, cervical length less than 25 millimeter, and biochemical predictors include fetal fibronectin in cervicovaginal discharge. The investigation included complete blood count, urine analysis and for culture and sensitivity, cervicovaginal swab for culture and fibronectin, USG for fetal well-being, cervical length and placental localization, serum electrolytes and glucose levels when tocolytic agents are to be used. Measures to arrest preterm labor include scope to arrest preterm labor is limited and majority is associated with maternal and or fetal complicating factors where the early expression of fetus may be beneficial. It is indeed unwise to attempt an arrest onset of labor in such case. Thus, only negligible proportion of cases where the fetus is not compromised, maternal condition remains good and membranes are intact, the following regime may instituted in an attempt to arrest the preterm labor. They are: first one is bed rest, adequate hydration, prophylactic antibiotics not routinely given unless there is an infection, tocolytic agent. There is a short-term therapy. The objective of short-term tocolytic therapy include to delay the delivery at least 48 hours for glucocorticoid therapy for lung maturation of the baby and in utero transfer of the patient to a unit more than which is more able to manage a preterm labor. If conservative therapy is not successful, tocolytic therapy is started. These drugs should be used when the potential benefit to the fetus outweighs the potential risk. Tocolysis, which inhibit the myometrial contractility. The commonly used are magnesium sulfate, terbutaline, intozine, and nifedipine. Contraindications for tocolysis include intrauterine fetal death, lethal fetal anomalies, non-reassuring fetal heart rate, severe IUGR, chorioamnionitis, hemorrhage, severe preeclampsia. Tocolysis. The goals are to transport the patient to a tertiary care center and give a time lapse for that means administer corticosteroids and to prolong pregnancy more effective when started prior to 3 centimeter dilatation. Not detect this that tocolysis improve any index of long-term prenatal or perinatal mortality or mortality beyond the steroid administration. The indications are less than 34 weeks of gestation and no evidence of infection, viable fetus, non-life-threatening maternal complication. Beta-mimetic agents like terbutaline and ritrodin. These drugs stimulate beta receptors which cause uterine relaxation. Ritrodin is administered IV or orally. Terbutaline may be administered IV subcutaneously or orally. Frequent monitoring necessary to observe for side effects of increased heart rate, shortness of breath, chest pain, decreased blood pressure, hypovolemia, decreased potassium and hyperglycemia and hyperinsulinemia. Before starting administration, baseline ECG, CBC with differential count, electrolyte glucose, blood urea nitrogen, PTM, PTT should be ready. Beta mimetic, that is terbutaline, act on beta receptors located in the smooth muscle. The dosage is 0.25 subcutaneously every 20 minutes to 3 hours. And when the maternal pulse not more than 120. Contraindications are cardiac arrhythmia, potential maternal adverse effects of tachycardia, cardiac arrhythmia, pulmonary edema, myocardial ischemia, and hypotension. Potential fetal adverse effects of tachycardia, hyperinsulinemia, hyperglycemia, myocardial or septal hypertrophy, myocardial ischemia. Magnesium sulfate interfere with smooth muscle contractility. Exact action is not known. Administration by IV infusion pump. Drug administration monitored for pulmonary edema, loss of determinant reflex, and decreased respiration and hypotension. Calcium gluconide antidote should be kept ready. If used, protocol is same as that of pregnancy-induced hypertension. Calcium channel blocker of nifedipine relaxes smooth muscle by inhibiting the transport of calcium, hence negotiating contraction for formation. Its dosage is 30 mg loading dose, then 10 to 20 mg for every 4 to 6 hours. Contraindications include cardiac disease, use caution with renal disease, maternal hypertension, avoid concomitant use with magnesium sulfate. Potential maternal adverse effects are flushing, dizziness, headache, nausea, transient hypertension. Fetal adverse effects are currently known. Prostaglandin inhibitors, indomethacin or indocin, inhibit prostaglandin stimulation of the contractions. However, after 34 weeks gestation, indomethacin may cause premature closure of fetal ductus arteriosus, increasing risk for fetal pulmonary hypertension. Dosage: loading dose of 50 mg rectally or 50 to 100 mg orally, then 25 to 50 mg orally every 6 hours for 48 hours. Contraindications: significant renal or hepatic impairment. Potential adverse effects include nausea and heartburn. Potential fetal adverse effects are constriction of ductus arteriosus, pulmonary hypertension, reversible decreased renal function with oligohydramnios, intraventricular hemorrhage, hyperbilirubinemia, necrotizing enterocolitis. During tocolytic therapy, assess for fetal status by means electronic fetal monitoring, uterine activity pattern, respiratory status, that is pulmonary edema is common side effect, muscular tremors, palpitation, dizziness, lightheadedness, urinary output. General contraindication of tocolytic are category 3 fetal heart rate patterns, intraamniotic infection, eclampsia, severe preeclampsia, fetal demise, fetal maturity, maternal hemodynamic instability, severe bleeding of any cause, fetal anomaly incompatible with life, severe intrauterine growth restrictions, cervix length more than 5 cm. Corticosteroids therapy, maternal administration of glucocorticoids advocated whether pregnancy is less than 34 weeks. This helps in fetal lung maturation so that incidence of RDS, IVH, and NEC are minimized. This is beneficial when delivery is delayed beyond 48 hours of the first dose. Benefits persist as long as 14 days. Either betamethasone 12 mg IM 24 hours apart 2 doses or dexamethasone 6 mg IV every 12 hours for 4 doses given. Betamethasone is a steroid of choice. Risk for antenatal corticosteroids are premature rupture of membranes, especially with evidence of infection, as the infection may flare up. Insulin-dependent diabetes mellitus, where the patient needs insulin dose readjustment, transient reduction of fetal breathing and body movement. Antibiotics use only prevent group B streptococcus infection in the neonate. Fetus Fetus should receive 2 doses if possible and may use ampicillin. The first management during labor. In the first stage, patient should be on the bed. Ensure adequate fetal oxygenation by giving oxygen to the mother. Strong sedatives should be avoided. Labor should be watched by intensive clinical monitoring. In case of delay or anticipating traumatic delivery, better to go for a cesarean section. Second stage, birth should be gentle and slow to avoid compression and decompression of the head. Episiotomy may be done to minimize the head compression if there is perineal resistance. Tendency to delay curtailed by forceps. The cord is clamped immediately to prevent hypovolemia and hyperbilirubinemia. Shift the baby to an NICU. The place of cesarean section include in the case of routine cesarean delivery is not recommended, but preterm fetus born before 34 weeks presented by breech are generally delivered by cesarean section. Lower segment cesarean vertical or J-shaped incision is made in this case. The nursing assessment during tocolytic therapy asks for the following: fetal status by external fetal monitoring, uterine activity pattern, respiratory status, pulmonary edema is most common adverse effect, muscular tremors, palpitation, dizziness or lightheadedness, urine output, patient education to signs and symptoms of preterm labor, patient education to signs and symptoms of infection. Nursing diagnosis: anxiety related to the medication and fear of outcome of pregnancy, risk for injury to the fetus secondary to prematurity, risk for complication secondary to tocolytic therapy, compromise family coping secondary to hospitalization. Decreasing anxiety. Now the contraindications and potential complication of tocolytic therapy. Explain the purpose and common adverse effect of tocolytic therapy. Provide accurate information on the status of the fetus and labor. Allow the woman and her support person to verbalize their feelings. Encourage relationship with other patients who are experiencing preterm labor. Injury to the fetus. Encourage the woman to assume lateral positions when enhance the placental perfusion, monitor fetus status and labor progress, assist with the delivery of the infant as needed, notify the care provider if signs of advancing labor occurs. Minimizing risk of the drug-related injury, maintain accurate intake output at least every hour, Assess the maternal vital signs in accordance with the facilities policy. Notify the primary healthcare provider if the maternal pulse is greater than 120. Assess for signs and symptoms of pulmonary edema. Periodically assess deep renal reflux to note the signs of hyporeflexia due to magnesium sulfate infusion. Excessive dosage or poor renal clearance may lead to magnesium toxicity. Discontinue infusion if adverse effect occur. Notify primary health provider. Educate the woman on tocolytic therapy, explaining the purpose and common adverse effects. Promoting maternal family coping and encourage private time for woman and partner, allow visitation with other children as tolerated by the woman, and encourage other family activities as helping with the homework. This will assist in maintaining the family unit. Community and home care consideration include ensure woman meets following criteria for home management, no evidence of active preterm labor, no evidence of intraamniotic infection, cervical dilatation is less than 3 centimeter, ensure protocols or orders are placed in each of the following, that is warning signs of preterm labor, demonstration of uterine self palpation by the woman, monitoring vaginal discharge, signs of spontaneous rupture of membrane, assessment of urinary frequency, signs and symptoms of urinary tract infection, frequent home visit by non-stress test, fetal heart rate assessment, vaginal examination, close healthcare provider in contact. Patient education health maintenance include educate the patient about the importance of continuing pregnancy until term for the fetal lung maturity, encourage the need for compliance with the decreased activity level or bed rest as indicated, teach the patient teach the patient the importance of proper nutrition, need for adequate hydration, teach the woman signs and symptoms of infection and report them immediately. Thank you for listening.